Okay, we are now live.
Excellent. Right. Good morning. Welcome to this meeting of the Health and Wellbeing Board. I'm Councillor Lee Chapman. I'm co-chair of the board, and I'm obliged to inform you that this meeting is being live streamed and recorded. Members of the public will be able to hear the audio of the meeting and view the papers shown on the screen. I'll now explain that this meeting is being held using remote technology, and should any committee members experience technical difficulties during the meeting, they should immediately contact the designated IT officer on the number they've been supplied with. Everyone is requested to mute their microphones except when being asked to speak, and please only use the chat function to request to speak. And I will call those who've put their items down on the chat to join the debate. I'd also ask individuals to introduce themselves as they speak, because although we'll recognise voices from colleagues in the meeting, those listening from the public may not be so clear. As chair, I will interpret the council's existing standing orders in light of the requirements of remote participation, with advice from the monitoring officer prior to making a ruling. Now, at the start of the meeting, I'm going to ask members of the board to confirm their presence and any disclosable pecuniary interests they may have in any items on the agenda. I will ask anyone that speaks during the meeting to introduce themselves. Yes, I've already said that. Okay. So I'll now do the roll call, and I'll go through each of the names of the members of the meeting and ask them to confirm their presence and confirm any interest they may have. So I'm going to go from this list I've got. Yeah, no, I'm going to go off screen. Okay, so Ed Potter, Councillor Ed Potter.
Present, no interests.
Thank you. David Evans.
Present, Chair, no interests.
Ben Hollands from MPFT.
Present with no interest, thank you.
Thank you, Ben. Good morning. Thank you for stepping in for Prof Iqbal. Jackie Jeffrey.
Yes, present, and my usual contract holder under the Better Care Fund.
Thank you, Jackie. Karen Bradshaw.
Present and no interest, Chair.
Thank you, thank you, Karen. Laura Fisher.
Present and no interest, thanks, Chair.
Thank you, Laura. Lynn Corley.
Present, no interests.
Thank you, Lynn. Nikki O'Connor.
Present and no interest, thank you.
Thank you. Penny Basin.
Present and no interest, thank you. Morning.
Good morning. Julian Povey.
Present and no interest, thank you.
Thank you. Chris Preston.
Present and no interest.
Thank you, Chris. Rachel Robinson.
Present and no interest, thanks, Chair.
Sean McCarthy.
Present, Chair, and no interests.
Thank you. Tanya Miles.
Present, Chair, no interest, thank you.
Okay. And we haven't seen Councillor Dean Carroll yet. Councillor Dean Carroll on the call? He'll join us when he can, no doubt. Michelle and Michelle, the committee officer, and Shelley are helping us manage the meeting and taking the minutes. Is there anyone who's in the meeting that I'm not aware of that I haven't called to identify themselves? Marvellous. Good. So we all know who we are. So the second item on the agenda, having dealt with declosable pecuniary interest, is minutes of the last meeting. There's two sets of minutes from the last meetings. If I could just take the minutes from the 14th of January. Are there any items that colleagues would like to highlight for accuracy before I arrange for those to be signed as a true record? A deafening silence. Thank you, colleagues. I will get those signed, and we also have the minutes from the meeting held on the 12th of November. Are there any items of accuracy that colleagues would like to highlight on those minutes? Just indicate in the chat box, then I will be able to see that. Okay, that's superb. So we're happy with those minutes. I'll make sure that those are signed as an accurate record. Thank you. So item 4 on the agenda is public question
Sorry
time.
to interrupt, Chair. We've not done the apologies. It's Shelley Davis.
Beg your pardon. Yes, of course we haven't. Yes, thank you for prompting me. So we've received apologies from Mark Brandreth from RJAH, from Ross Preen from Shropshire Community Health Trust, and from Louise Barnett, Chief Exec, although we're grateful to Chris Preston for substituting for Louise. We have had apologies from Nikki Jakes, Chief Officer at SPIC, and that's Shropshire Partners in Care, I beg your pardon. And as I mentioned earlier, Ben Hollands is currently substituting for Professor Iqbal from MPFT. I'm not aware of any other apologies, unless my colleagues are aware of any others.
Chair, apologies.
Yep.
I don't seem to have the hand function on my guest invitation to this Teams meeting. Just to let you know that Zafar will be joining us at 11, and I'll step out at that point if that's okay.
Yeah, that's fine. Thank you, Ben. That was the message that I'd got. So thank you. No, there isn't a hand function to put your hand up, Ben. What you have to do is, if you go to the little bubble with the chat feature, you type into the chat that you want to speak, and then I'll see people as they indicate, and then I call you in. So on public meetings, there's no hand raising. We use the chat feature. Okay, so that's dealt with apologies for absence and substitutions. We've done the minutes. Item 4 on the agenda is public question time. This is an opportunity for members of the public to submit questions to the Health and Wellbeing Board in advance of the meeting, and for us to arrange for those to be answered. We have had no public questions prior to this meeting, so we will carry on to item 5. Sorry,
it's Julian. My chat function says it's muted at the moment.
Your chat isn't muted. Your message came up.
All right, okay, it just says at the top. I can't do the. Oh, right, no, that's fine now. Yeah, it's working now. That's brilliant. Sorry about that. Yeah. Excellent. Thank you. Not a problem at all. We need to make sure that everyone is readily able to facilitate access to the meeting. So I'm happy that that's working for you, Julian. So item 5 on the agenda is the system update. We're doing this in 2 parts at today's meeting. The first part is the STP update, and Nikki Connor, who introduced herself earlier, is going to be taking this item for us. I understand that you may have a presentation which wasn't received in advance for us to be able to put it here. So unless you're able to share your screen, we can't enable the presentation. So what would you like to do, Nikki?
Thank you. I haven't got a presentation that I can readily share, so perhaps if
you're talking through the report that we've had.
Yes, that's exactly what I'm going to do.
Fine.
And you'll also sort of indulge me. If I take the first part of the report, which is around the ICS and the commitments that we're making there, I'm going to ask Dave Evans if he would mind covering the update on winter planning and vaccination, because he's closer to those issues than I am. So just by way of an update on, I mean, it says SDP there, but we are all heading to becoming integrated care systems. So we have been operating in shadow form for the last year or so. We expect that we will be approved to become an integrated care system from April this year, though there will then be a journey for the next year ahead to become a fully mature ICS from April 22. The white paper that underpins all of this came out on the 11th of February. It was anticipated, but just sets out the legislative framework that will underpin integrated care systems becoming statutory bodies from April 22. The purpose of all this is to remove the barriers that currently exist within the health and care system that stop integrated care becoming more of a reality in essence. So this is about using our collective resources across health, local authorities, the voluntary sector and other partners to ensure that we're giving the best possible care to the citizens of the area, and taking a much better approach to population health, so that we're truly thinking upstream about those issues that affect the health of the population, thinking about how we can take preventative measures to support people to live better and healthier lives, and also about what interventions we can make when people become ill, but make those interventions earlier rather than later when they become very ill. This system has produced a plan. I think we went through it a little bit last time, but I'll just briefly go through it again. The plan contains 10 pledges, which are all around improving health and care. So the first one is about improving safety and quality, an issue that is very pertinent to the system and very important to everybody. The second pledge is about integrating services at place and neighbourhood level. So one of the key underpinnings of an integrated care system is that the care should happen as close as possible to where people live and work, and we have 2 places within the STW system, and that is where the majority of care should happen, and at neighbourhood level, so that people can access care in the best possible way. The third pledge is around tackling the problems of ill health, health inequalities and accessing healthcare, and that speaks very much to a more integrated population health approach. The fourth pledge is about delivering improvements to mental health, learning disabilities and autism provision. The fifth, and I think the fifth and sixth are where we truly start to see the benefits of becoming very joined up across the system. So the fifth pledge is around economic regeneration. We know through the pandemic that there will have been significant impacts upon the economic well-being of citizens. And this pledge is working very closely across local authorities and health to enhance opportunities that can be brought around creating jobs, creating better housing and improving the health and well-being of the population as a whole. The sixth is about climate change. Local authority partners have had significant strategies on climate change, and we're now trying to bring the health aspects into that and make that a much more joint effort. The seventh pledge is around our leadership and governance, so just essentially making sure that the systems we have underpin that better delivery of health and care. The ninth pledge is around creating a more sustainable system in the future. We have some fairly significant challenges in the system around our finances from a health perspective. This is rather than a local government perspective. And we are looking to see how we can make better use of the resources that we currently have. And the fifth pledge is around our workforce. Always a consistent challenge in terms of the delivery of health and care, and a more joined up approach to how we recruit people, how we retain people, how we make the health and care system a place people really want to work, will enable us to deliver much better services. So I will pause at that point. I don't know whether people want to make points now, or whether it would be best to pass over to Dave to talk about winter planning and the vaccination programme. Happy to be led by you on that.
Okay, yeah, thanks, Nikki. So for clarity, there was questions from one colleague about whether the paper had actually been received by members of the board. It did come late to us, and I just clarified that it did go out on email yesterday morning. So for colleagues who hadn't seen it, then it did come out late. It has gone on to the website for the Health and Wellbeing Board with the associated papers. But obviously, just for clarity, for those who perhaps hadn't seen the paper and don't look at their email quite so religiously as I do, or don't have the time to, we have had the paper. I think colleagues are coming in requesting to make comments at this stage, so I think we'll take those now, Nikki, and then we'll move on to David afterwards. Julian Povey has indicated he'd like to speak. Perhaps I could ask colleagues just to introduce themselves as they come in to make comments.
I am Julian Povey. I'm a GP and chair of Shropshire CCG. Just a couple of comments really, and one is whether it's perhaps to flag something that perhaps the Health and Wellbeing Board needs to do at a later meeting, and that's have a more detailed discussion about the two things. One is the actual white paper, the integration and innovation working together to improve health and social care for all, because there's some, it'd be worthwhile having a discussion, I think, with the ICS team and the SDP team around that, because that talks about the creation of having three types of board. It talks about a statutory ICS NHS board that sits over the ICS, that's got the council chief execs and the chief execs of the hospitals and a representative of primary care. It then talks about having this NHS the health and care ICS board, which is going to be a statutory board that sits almost between the NHS board and the Health and Wellbeing Board, and then having the Health and Wellbeing Board as a separate board. So each of the boards within the white paper has got different functions, and I think it's probably important for the Health and Wellbeing Board to understand what those boards are doing. So I think probably there is a need for a more in-depth look at that white paper from the Health and Wellbeing Board perspective. The other thing is a paper that came out at the same time around the white paper was the consultation on the NHS provider selection regime. So Nikki's right that the main thrust of the white paper is to remove competition and allow collaboration and allow health organisations and third sector organisations to work in collaboration without having to everything go out to the market for procurement. But there is a bit within the consultation about AQP, which I think is something that people can feed back onto, and whether the Health and Wellbeing Board, separate to the council and separate to the CCG, needs to feed back on, because that talks a lot about the removal of the competition and collaboration. But the AQP bit is interesting. They're suggesting there that any consultant-led first outpatient appointment will be available for AQP. So AQP is any qualified provider. So it allows any organisation that is prepared to hold an NHS contract, prepared to accept NHS prices, and prepared to work to the NHS constitution, and prepared to work with local referral thresholds, to apply to deliver any service that is basically a consultant first led outpatient. So I think there's huge challenges and issues within that, and it's something that people need to be cognizant of, and probably we need to be feeding back into, because that risks organisations cherry picking from our system, things that are easy to do, that are easy to make potentially profit on, and allow that money to come out of the system without any control. It says that the AQP isn't going to be open to a process so that anyone could apply, and the ICS can't limit who applies to be on their list. And once they're on a list, they have to be available for GPs to offer choice to. So I think it's an incredibly important bit that I think a lot of people aren't aware of, that is within these proposals that should be debated and probably fed back on into later meeting. I don't know if Dave would like to add a bit more to that, but that's certainly something that I'd like to highlight. And then the issue within the white paper around the relationship between the Health and Wellbeing Board, the NHS Care and Health and Care Board, and the NHS Board of the ICS.
Thanks, Julian. Dean Carroll's just joined the meeting. Dean, perhaps you could just introduce yourself and confirm your disclosable pecuniary interests.
Good morning, Chair. Yes, I can confirm I'm now present. I'm Councillor Dean Carroll, portfolio holder for adult social care, public health and climate change. I can confirm I've got no disclosable pecuniary interests, and I apologise for being late. I was on the phone to one of my constituents.
Not a problem, Dean. Thank you, and good to have you here. We're on the first item, the STP update, particularly looking at the work to form an integrated care system. And David Evans, who's going to introduce himself, is going to speak next.
Thanks, Chair. I'm David Evans. I'm the Accountable Officer for Shropshire CCG and Telford and Wrekin CCG. And if I can just make a comment following on from Julian's a second ago, before I move on in this particular agenda item. The point Julian raises around the AQP, I think, is particularly significant. It's no secret, obviously, that we have a significant financial challenge within this health economy, and the potential risk around first consultant appointments and AQP and the cherry picking that Julian mentioned, I think does make our planning for a robust financial strategy much more complex, and we need to work that through. But I would agree with Julian. I think it is something that Health and Wellbeing Board will want to consider over the coming weeks, and may well want to have a discussion around. So if I move on, Chair, if that's okay. If you will indulge me slightly, I noticed that COVID is on the agenda later on with Rachel, and I wonder if rather than touching on COVID now particularly, it might be better to try and cover all of that off in the one agenda item to avoid duplication and risk stealing Rachel's thunder at this point. So if that's okay, Lee, I'll leave the COVID bit for now.
Yeah, I'm glad that you suggested that, David. The thought had occurred to me when I looked at the papers that have been tabled, so I think that's helpful to bring that together as one item. My comments going back to the integrated care system update. I think it's quite interesting that the report concentrates on very much the strategic approach to forming the structures and some of those pledges as you've put in your submission. They're not very patient or people friendly in terms of their approach, which I think for a public facing document I thought was quite interesting. So if we bear in mind that these are drawn from the long-term plan, what I don't think it talks about is this issue that we first saw come out in the long-term plan around the approach to supporting self-care and looking at resilience in communities and attempting to support those, and I perhaps quite rightly the pledges concentrate very much on service delivery and the mechanisms around the way that existing services and the existing processes within the system will be reimagined and redelivered. And I just think that if we're going to, when we start wanting to talk more widely, and certainly from a health and wellbeing point of view, when we want to start talking more widely about this, I think we are going to have to start thinking more about what the opportunities are and how is it going to feel different to our communities across Shropshire, as opposed to it just being something that we're sort of internally doing. Perhaps that's not a fair challenge, but I think for me that's what it felt like.
If you wouldn't mind, if I just come back on that. So thank you for those comments. I think that's almost a product of where we are just at this moment in time, and a legislative framework just having come out. But entirely accept your comments, and I think let's try and address that more next time when I give a further report. I think those are very fair comments.
Okay, so my recommendation is that we work, picking up on comments made both by Julian and by David, that we actually schedule something into the diary from a health and wellbeing board point of view, to actually look as a board at some of the issues arising out of this, and actually decide what stance we're going to take and what recommendations we as a board would want to make, because I think we need to be the challenge with health, with the NHS and healthcare and its relationship with local authorities and partner organisations has always been about how we interpret top-down mandate and regulations and legislations so that it's appropriate for our local circumstances here in Shropshire. And that can only really happen if we contribute to the shaping of that. I'm sure that the board would want to be confident that they've had every opportunity to shape and to input into these emerging proposals. So I think it would be helpful if we could look as part of the planning for future health and wellbeing board meetings, if we have a discussion about how we bring that to the board and how we take the benefit of the membership of the board to make best use of that. Thank you, Nikki, for bringing that paper to us. If there aren't any other, there are another contribution. David Evans would like to come back.
Thank you, Chair. It was just to finish off the report in terms of the winter planning, if that's okay.
Of course.
And clearly I don't want to again go too much into some of the aspects of this, because we will cover it later, because clearly winter planning this year has been significantly impacted with COVID and the rise of COVID in prevalence and impact on healthcare and social care services over the winter period. So we'll pick much of that up later on. Just one couple of things I did want to pick up, though. I mean, clearly the impact of a third wave of COVID has impacted on the ability of local services to continue functioning at the level they were before. We are now working through the plan of restoration again and how we can deal with some of that moving forward. And there is a plan to move staff back into Robert Jones and Agnes Hunt from SATH, because they've certainly been supporting SATH over the past couple of months or so around particularly critical care, and we do need to start looking at how we can start to restore some orthopaedic services as well as other services moving forward. So we'll bring something back on that in due course in terms of where we are and the complete plan around that. The other thing I just wanted to pick up, though, was NHS 111 implementation, which, as you know, went live in terms of NHS 111 first towards the end of last year. We are seeing some impact around that, into a positive impact around that in terms of emergency department attendances, and that was 17% down by the end of December. So I did just want to draw Health and Wellbeing Board's attention to those two particular aspects, Chair.
Thank you, David. And colleagues may be aware. Good. Lynn would like to come in on an item that I was going to mention. So, Lynn.
I just wanted to follow on from what
Sorry, so Lynn Corley from Health Watch.
Sorry, yes, thank you, Chair. I just wanted to follow on from what David said. Health Watch Shropshire and Health Watch Telford and Wrekin have just launched a survey to understand people's use of A&E through urgent and emergency care, which will touch upon their experiences of using 111 first. And we've just launched that earlier this week, so we'll be able to report back to the board later on in terms of the findings. Thank you.
Thank you, Lynn. It sounds much better coming from you rather than me saying, oh, I think I saw something earlier this week about this. Thank you. Okay, so the next item, if colleagues are happy with those updates, is around the Better Care Fund update. And we have had a paper on this submitted as part of the agenda items, and I understand that Penny Basin, who's going to introduce herself, is going to take this for us. Thank you, Penny.
Morning, thank you, Chair. Penny Basin, Head of Joint Partnerships for Shropshire Council and Shropshire CCG, joint post. So yeah, thanks for the opportunity to bring the to the Health and Wellbeing Board, the Better Care Fund. So as reported at the last Health and Wellbeing Board in January, in December we received the guidance for the Better Care Fund for 2020-21, and then we agreed that we would bring forward that plan for this year to this board, along with Section 75 Partnership Agreement. So within the guidance that arrived in December, it was stated that the Better Care Fund plans didn't need to go through the national approval, which made sense given the year that we've had and I suppose the late arrival of the guidance. And in that way, I suppose our Better Care Fund has pretty much rolled over from the previous year, with plans in place going forward to next year, looking forward to how we can support the Health and Wellbeing Board and how we can support the development of the ICS and the subgroups of the ICS. So although the guidance doesn't have to be approved nationally, the Health and Wellbeing Board still does need to approve the schemes and the spend. And also we do have to, as part of the national conditions, update the Section 75 Partnership Agreement. So I just addressed the Partnership Agreement first. In September this year, the board agreed the schedule, the new schedule, which supported ways of working around COVID for the Section 75 Partnership Agreement and how the additional grant spend would be made across the organisations. That was agreed in September, and the final document is attached to this report to be noted for the board. So it's the kind of the schedule turned into the legalese around the Section 75 Partnership Agreement that both the Shropshire Council and and the CCGs have signed. So that's to be noted by the board. The second element is the Appendix A, which is the spend. So again, that's separated into a number of elements. Within the spend that's managed by Shropshire Council, there is the key elements of the pooled fund, which is the fund that is passported across to the council from the CCG and jointly agreed on how we spend that money. There's the additional Better Care from the original IBCF and the additional IBCF spend as well, Winter Pressures Grant, the Disabled Facilities Grant, and additional contribution from the local authority. So those are spent, like I said, largely follows across from previous year, those spends, and have been agreed through Joint Commissioning Group. On the second page of the spend is the CCG's managed portion of the budget, which again follows from previous years, and there is a note there to say where, so eagle-eyed people would note that some of those schemes such as care closer to home. We're kind of operating under a different guise this year, in particular with regard to COVID, but then also in regard to block payments across to our provider organisations. So although they're listed in a particular way there as part of the spend, I think going forward we'll be looking more significantly at those lists and seeing how they can support our strategic direction through the ICS and the Health and Wellbeing Board in future years. So I think, Chair, I'll stop there and take any questions or comments.
Okay, thanks, Penny. It's a good report. Certainly makes it clear where all of the money is being allocated, which is very helpful. Tanya Miles, if you could introduce yourself, I'd like to make a comment.
Thank you, Chair. So Tanya Miles, Exec Director for Adult Social Care, Public Health and Housing. So thank you, Penny, for that report. And a suggestion, if I may, Chair, for our next Health and Wellbeing Board is to ask for an evaluation on prevention and admission avoidance. So the reason why I say that, we know that this winter has been an interesting winter and quite challenging, but we have had the fabulous WIPS contract, that's the Wellbeing Independence Partnership. They're currently doing an evaluation of the work that's gone on over this winter, and I'd welcome Health and Wellbeing Board's oversight of that evaluation at next board. And then the second area is around Shrewsbury Emission Avoidance Service, which has now been named our Rapid Service. This is an integrated joint team between the local authority and Shopcom. And again, that's also going through an evaluation over the last few months of activity. So this is around supporting individuals living in the SY1, 2 and 3 area. So I think it would be a great opportunity for us to have that team come into Health and Wellbeing Board in terms of raising the profile, but also the evaluation of the impact on this system. Thank you, Chair.
Thank you, Tanya. That's very helpful. Okay, any other items or comments on that? Okay, helpful. I think that we're still receiving the funding. I know from previous comments, the fact that we don't have this sustainably put into our budget for the longer term, I think, is still an ongoing irritation. Nevertheless, we seem to manage to pull all the stops out at the last minute and get it all drawn together. So thank you, Penny and colleagues, for organising that and for bringing it to the board. If there's no other comments, I've got a little list of items for the next board meeting, and I've made a note of those that Tanya recommended. So if the board is happy to note those the items on that paper, so that is both the legal agreement and confirmation of the commission schemes across the various budgets. I'm happy to propose that. If I could have someone to second it, that would be helpful.
I happily second, Chair. Councillor Dean Carroll.
Thank you, Dean. And unless I hear otherwise from colleagues in the chat box, I'll give everybody a minute or so. Unless I hear otherwise, I will formally approve those papers. So thank you for that, Penny. And we will go on to the next item. So item 6 on the agenda is the thank you, Jackie. We'll note your abstention. Thank you. Jackie Jeffrey is abstaining from that last vote. So item 6 is the joint strategic needs assessment update, and I'm pleased that Rachel, who's going to introduce herself, is going to take this paper for us. Thank you, Rachel.
Thank you, Chair. So Rachel Robinson, Director of Public Health. The paper that we've included this time in the pack on the Joint Strategic Needs Assessment is an update. So we agreed at the last Health and Wellbeing Board that I would bring regular updates to the board just to keep it keep the board updated on the progress around the GSNA and the movement between each of the meetings, and any actions that we need the board to be aware of, and obviously to ensure that we continue to involve the board in the progress. So the paper is really an update over the last 6 weeks to assure the board that we are moving forward. There's 4 particular elements of update included in the paper. The first is around best practice, to assure the board that we've been speaking to colleagues across the region, particularly to understand how the GSNA, particularly the place-based approach to GSNA, has been taken forward in other areas and to learn from other areas. The second piece of work that we've been working through over the last 6 weeks is around geographies. So we'd agreed at previous meetings and boards that the geographies would be aligned broadly to our place plan geographies that we have in Shropshire, which are developed around particular communities as communities see themselves, so that makes sense to our local population. Within that, we've recognised in this paper that we will, of course, try and get down with our information to as low a level as possible, so including wards and other geographies, but also we will try and build up to other geographies that are meaningful across our system. So obviously within our health and care system and within our communities, people understand different geographies. So the idea of this GSNA is that we can use these as building blocks. And there's a table within the report that just outlines where that overlap is. The key area we'll be working on between this and the next meeting and starting to deliver our GSNA is which areas how we will work that first. And I'm suggesting there will probably be a spread of geographies across the county aligned to kind of our primary care network areas to make sure we start to cover each of those areas with one of our place-based needs assessment. The second element that we've begun to move forward is the delivery model, and put a little bit more flesh onto the conversations we had at the last meeting, which is really to start thinking about the role of members of this board and their important contribution to the GSNA. As we've said throughout this, it's the responsibility of all partners to engage in the GSNA process on the board. We had a good discussion at the last meeting around what those roles would be, and you'll see within the table we proposed a little bit more detail about what those roles and contribution could be. What I'd like to suggest is obviously that members come back to review that table, and obviously through this meeting, but outside of this meeting as well, come back with comments about their contribution. The final element of the paper then, within that we've also included information on governance and the governance structures we will be setting up between this meeting and the next board meeting. And again, we're looking for contributions and nominations for those roles on those that strategic group that will take forward the delivery of the GSNA, and also obviously the individual steering groups that will be set up to deliver each needs assessment. So we're looking both leadership nominations and also analyst nominations, and we'll be coming out to members of the board asking for those nominations after this meeting. And they will be developed the terms of reference as we go forward. The final part of the paper demonstrates the delivery model that we're looking at and gives an indication of how we see the rollout actually of the place-based GSNAs happening as we get into those, but just to give again board members an indication of a little bit more detail of what this means in practice in the delivery. And then the final element that is just to update colleagues on the SEND GSNA, which is a particular needs assessment that we need to complete. So it's not the whole piece, but it's one particular needs assessment that we've committed to completing. It was the third of our needs assessments, if colleagues remember, that we now have appointed somebody to be able to begin that work. They start on the 15th of March, but we've already begun work in the meantime to look at the structure of the report, start collecting information for the needs assessment, and I'm hoping that we can bring that report back to the next board meeting as a draft. So I'll just pause there.
Okay, thank you, Rachel. There's a note from Karen Bradshaw. Karen, did you want to come in?
Sorry, Chair, slow to get off mute. Not really. I think my comment sort of says it all. I'm really pleased that we've got an appointment to that post so that we can move that GSNA forward. It was identified as a key priority in our SEND, and I'd be really looking forward to the next board meeting when we can see perhaps some of the first outcomes from that. Thank you.
Yeah, okay, thank you, Karen. I was just conscious that comments in the chat box aren't heard by members of the public who are attending the meeting, so that was the reason. Thank you for that.
Thank you.
Jackie, you wanted to come in. Could you introduce yourself before you speak, please?
Yes, I'm Jackie Jeffrey, and I'm the Community and Voluntary Sector Assembly rep on the board. So my comment is about what you just said there, Rachel, about us being able to go away and talk to our partners to feed back into this. And so the
Jackie,
yeah.
just hold on, just bear with me just a minute. I'm just going to ask everybody else to mute themselves, and then we'll just ask you to start again because your line is very scratchy.
Is it?
Yeah,
sorry.
Yeah, just hold on just a second. I'll mute myself and then you start.
Okay. Okay, is that all right?
Yeah.
Yeah, okay. Yeah. So my question was about the table there, about all the people involved in the JSNA and the community and voluntary sector element. And Rachel, you said that we could go away and talk with our partners or in our roles and to feed back in that. And I think it's just a little comment to make that where you put as the community and voluntary sector's contribution to the JSNA is to help identify third sector assets, and that you can use our outputs and to utilise the outputs in planning and bid for bids. So, you know, we're a bit more than, you know, just fodder for writing bids and creating evidence. So I want to go away, if that's okay, and take that back to the board for discussion, because I think there's a lot more that we could bring to the JSNA to make it live. We talk a lot about stats and things, but what the sector's really good at is bringing that qualitative data as well as the quantitative data. And also the point being is that when the voluntary sector is asked to contribute towards big bids with the council, can those requests go through the voluntary sector assembly and not just directly to the usual suspects or kind of voluntary sector organisations? Can get around a bigger debate and accountability if we go through the assembly. That was just some of the feedback I've been getting on the board about approaches to voluntary sector agencies to be part of bid writing. I think we're a bit more, I suppose in summary, a bit more than just outputs and bid adding validity to bids.
Yeah, thanks, Jackie. So yeah, I mean, absolutely well taken. I think just to clarify, I guess, what's in there, but I mean, firstly, these are only proposed, so absolutely we need to develop them. I think what within those kind of involvement rule was to try and describe the scope and the really important role of each of those, each of partners within this. So I think the bit that you've talked around the evidence base, that qualitative is the bit around supporting the evidence base, the engagement, all of that, bringing together that qualitative bit that you talked about is absolutely what is, I think, meant, but probably not explicit in that, and supporting building the evidence base, because the evidence base isn't just around data, it's about everybody owning this. I think the bit around the bids, actually, I think the point in there, the outputs obviously are used for, it's a joint strategic needs assessment that's used for commissioning, but for me it's much more than commissioning. It isn't just about commissioning, it's actually about us people on the ground being able to use it. So the bids I think we were referring to was actually, it was one of the example of how colleagues and partners across Shropshire can use this. So actually it wasn't about the council necessarily accessing funding, it was more about organisations themselves feeling that they've got the evidence to support to say, we've gone through this process as a council, as a council area, I'm talking geographically, so it's not the council, we've gone through this as partners, we understand what our needs are, these are the key needs that we've got, and therefore all of this data, it helps organisations, community groups, everybody to be able to access some of those funds because we understand what our needs are, and this is the evidence base around that. So it probably isn't explained very well, but but I just wanted to explain that a little bit more, but also to say absolutely it's so much more than just those areas, and it isn't just all of these are not light touch involvement. It's about everybody owning it, feeling it's their document, they can shape it. We don't have the information. I don't as a team have all of this information, and if I just sat and did it in isolation, it wouldn't be what it's supposed to be, which is owned by everybody and everybody's document, and it needs to be shaped. So really want, if colleagues can go away and absolutely Jackie come back and shape it, and we can amend this. It's very much draft, and we need to set up the group so we can really get that input, which we haven't been able to get over the last 5 weeks. I really want it to be shaped and owned by colleagues, so absolutely happy to take all of that on board. Thank you.
Thank you, Rachel. That's brilliant. That makes it, you read it completely differently. Thank you, and I really appreciate your approach because you're very inclusive. So thank you very much.
Thank you.
That's good. Thanks, Jackie. the reference to bids, I'm assuming in that is not the bids that are referred to in the table, because the bids in the table are business improvement districts, not bids for funding. Just for clarity, I'm sure that's what everyone else understood, but just so we're all clear. Dean Carroll, if you could introduce yourself, you'd like to come in.
Thank you, Chair. Yes, Councillor Dean Carroll, portfolio holder for adult social care, public health and climate change. I just really want to endorse and support everything that Rachel has said so far, and to give a little bit of context and background to actually quite what an achievement has been to get this here, and actually to get a new and reimagined version of the JSNA through. Writing a JSNA is usually quite an intensive piece of work in itself, and would normally be one of the most significant things that public health and health system partners would be looking to embark upon at the time they did it. But given in the context that this is mid-pandemic, in what is the most challenging health and care times, certainly this century, I think it bears remembering and holding in context that this has been done alongside those challenges, and to thank Rachel and all partners and our officers that have contributed to this to get us to where we are at the moment, and to welcome, as Karen has said, the renewed focus on SEND JSNA and a specific focus on that. Thank you, Chair.
Thank you, Dean. Any other comments from colleagues around this update? Okay, thank you. And thank you, Rachel, for that. You're coming back to talk to us around vaccinations and a COVID update later in the agenda, aren't you? So if everyone's comfortable with that, the recommendation on the report is that the board notes the contents of the report, and as my colleague Councillor Carroll has said, notes also the considerable amount of work that sits behind this and will be facing all board members going forward. But I'm happy to propose that. Are you happy to second it, Dean?
I am, Chair, yes.
Okay, that's fine. And so if I don't hear from any colleagues in the chat function, I will assume that everyone is comfortable that we note the contents of that report. Thank you. So item 7 on the report is the Armed Forces legislation. And in Shropshire, we have an Armed Forces Covenant lead, Sean McCarthy, and he is going to start us off on this very important piece of legislation and the implications for us as a health and social care economy. Over to you, Sean.
Thank you, Chair. Yeah, as the Chair has said, I'm Sean McCarthy. I'm the Leisure Services Projects Officer, but I also have the responsibility for the delivery of the Armed Forces Covenant. Thank you for allowing me to present this this report this morning. So just as a way of starting, the Armed Forces Covenant is there to remove disadvantage to the Armed Forces personnel and their family members, which has been around for some 10 years, near enough. The Armed Forces Act 2006 sets out the requirement for the Secretary of State to lay before Parliament an annual report that covers the membership of former personnel around healthcare, education and housing. The government is further committed to enshrine the Armed Forces Covenant into or around further legislation in its Green Speech later this year, which will focus around public authorities that have the responsibility for education, housing and healthcare. These are put into what they're terming having due regard, which are around the 3 principles the unique obligations of and the sacrifices made by the armed forces, and the principle that it is desirable to remove disadvantage arising from service personnel from membership or former membership of the armed forces. Service personnel may include serving personnel, veterans and their families. And the final one, the principle of a special provision for service people may be justified by the effect on such people of membership or former membership of the Armed Forces Covenant. So moving to the legislation, and as I said, this is proposed at the moment and is in the process of working its way through Parliament and ultimately onto the House of Lords and beyond there. So as I said, the Covenant has been around in operation for 10 years. The government therefore proposes to introduce new legislation to further what we've already got. The aims of the legislation is to increase awareness among service deliverers and policymakers of the unique obligations and circumstances facing the armed forces community, and that's really around embedding that understanding in public sector decision making via the new statutory duty around due regard. The legislation will focus on the proposed will be around local and regional service provision, covering those aspects of public housing, education and healthcare. Reflecting on the three areas covered by the existing Armed Forces Covenant legislation, these three strands of policy also comprise the foundation of a successful life and are commonly raised areas of concern for the armed forces community. So the legislation, as I said, is around the new duty that will apply to relevant public bodies exercising their public functions around education, healthcare and housing. The private sector is not in scope around this legislation. Legislation will be enforced, or well, there won't be new measures put in place. It will be supported by the existing complaints procedures and, where relevant, the appropriate Ombudsman Office. Where any issues cannot be otherwise resolved, enforcement of compliance is by way of judicial review in accordance with the standard public law principles. The due regard measure, which is mainly where the legislation is going to fall down on, as I said, is those public bodies in scope that I've mentioned will be required to have due regard for the three principles that I've mentioned earlier in my report. This report is really just to bring an early sight to the board and what the potential impact of the new legislation may be on public authorities around the three areas that I've mentioned. The legislation is still very much in draft. It is, as I said, going through the relevant procedures in government before it's coming into effect later on in the year and stuff. So that's the legislation in a nutshell. There are a couple of other points within the report, Chair, that whether you want me to pause now around the legislation before I move on to some of the other points that I've highlighted in the report. I'm quite happy to take questions now if anyone has any.
Okay, yes. I haven't had anyone indicate at this stage, Sean, so if you carry on to the other part, that would be fine and we can pick them up afterwards.
Thank you, Chair. So just some of the work that we're doing specifically around health in Shropshire and the Armed Forces Covenant. One of the areas that we're keen to increase is the amount of GP practices that we have that are GP friendly accredited. In the report, there are around, I think, 11 GP practices that are currently signed up. That was as of the 10th of February. So we're particularly keen to work with GP practices and others to increase that number, which focuses around asking current and new patients if they have served and then coding them appropriately. We've been doing some really positive work with SATH and Robert Jones and Agnes Hunt Hospital to support them to become veterans aware. Particularly with SATH, they now have in the region about 30 or 40 Armed Forces champions within the trust that support both staff within the hospital that have a connection with the armed forces, but also patients who are coming into the hospital that have an armed forces connection, so they can support them whether it be an outpatient appointment or whether it be for a particular time that they are actually in the hospital. We've also just recently, towards the back end of last year, completed a Shropshire and Telford and Wrekin Armed Forces Needs Assessment, which there was around about 30 key recommendations, some of which are health related, housing related and education related, which we're working through at the moment, which may link into the proposed new legislation. We have strong links with our service charity sectors supporting veterans and members of the armed forces community. And then we have a number of groups that pull together some of this work to support us, to support members of the armed forces community in Shropshire. And we're very thankful of the support we get both internally within Shropshire Council and some of our teams within the council, but also our external partners, both service charity wise and from the business community. We've also been working really hard on engaging with the business community and other organisations to sign up to the Armed Forces Covenant and to make bespoke pledges to their organisation to support their own staff and how they engage with the Armed Forces community in Shropshire. To date, we have 106 organisations across Shropshire, Telford and Wrekin that signed the Armed Forces Covenant. That is the highest number of covenant signings we have in the country outside of the South East and stuff. So that's something that we're really proud of and wouldn't be able to do the work we do without the support of the business sector and also other organisations that support either its own staff or how they engage with the armed forces community. That brings me to the end of my report, Chair, and happy to take any questions if there is any.
Thank you, Sean. Excellent report, and as you say, we're fortunate in having a huge and vibrant community around the Armed Forces Covenant in Shropshire. Councillor Dean Carroll wanted to speak.
Thank you very much, Chair. Councillor Dean Carroll, portfolio holder for Adult Social Care, Public Health and Climate Change. And I'd like to thank you, Sean, for this report and for the work you do. I know from my previous involvement with the Armed Forces Covenant work in previous roles within the council quite how well we've done within the existing legislation. And as you said, I think we have the widest range of, the greatest range of signatories of any covenant outside of the southeast of England, which is really tribute to your hard work and that of your predecessors. This is always quite personal for me, because my late father had a long career in the armed forces. So anything that takes away, removes discrimination and hurdles in the way of our veterans and their families is something that's very close to my heart. I think the proposed new legislation is a good improvement. I think we would all have to recognise that it doesn't go far enough, but it is a stepping stone. It is a step in the right direction. I think we should be advocating in future that it should include private sector organisations as well. But I think that as a stepping stone, this is an important step. It will help us to expand the work we do, the work you do, the work our partners and the various representative organisations and charities such as SAFA and the Legion, the fantastic work they do to support our veteran community. So I'd thoroughly endorse everything you've said and this report and happily move it, Chair.
Okay, thank you, Dean. Jackie Jeffrey asked to speak. We'll mute ourselves, Jackie, so that we can get the best from your line.
Sorry, I didn't ask to speak.
Okay, Jackie, no problem. It must have been a message from earlier. My apologies.
Yeah, sorry. It's okay.
Penny Basin asked to speak.
Thank you, Chair. Penny Basin, Head of Joint Partnerships, Shropshire Council, Shropshire CCG. I just wanted to say that I think for me, as I was listening to Sean, although we've had a few conversations about it, I was thinking this sits so well within the personalisation agenda of the NHS. And there's a lot of opportunity for us to do some joint work on this. And I have spoken to Sean already about this, but I'm happy to put myself forward to the board as a kind of support for the work going forward to link, I guess, stronger links with the Health and Wellbeing Board, the Armed Forces Covenant, and into the CCG partnerships and the PCNs in particular, just thinking through how small changes, small notifications can around somebody who might have served, be a veteran, and how we can actually think of that person as a whole person and kind of work through that as they are come into services. So I think there's some really good work we could do with that.
Thank you, Penny. We've made a note of your volunteering and offering to do that. It's greatly appreciated. Thank you, Penny. Julian Povey, if you could introduce yourself. Julian, you'd like to speak?
Yes, thank you, Chair. I'm Julian Povey, Chair of Shropshire CCG. Now, welcome the report from Sean. The Armed Service Covenant, clearly incredibly important. I'm lucky enough to be in one of the practices that are signed up to be veteran friendly accreditation. The one couple of opportunities I'd like to highlight to Sean, and I don't know if Nicky O'Connor's still on the call, but I know Dave Evans is, and I wonder whether although they're not quite statutory organisations, whether in fact we should take a lead and see if we can get the ICS STP to sign up to the Armed Forces Covenant, and also the PCNs. I know Penny mentioned the PCNs. And I think it's also probably fair to question whether we should be highlighting in the STP ICS plan about veterans, because I have read our submission, and I don't think it mentions veterans healthcare anywhere, and I think that that clearly is probably an oversight and maybe something that does need to be addressed. So I think it's the opportunity for Sean to work with the PCNs and the ICSs that I'd like to sort of highlight.
Excellent. Thank you, Julian. A very good suggestion, and the synergy of the ICS paper today and those principles, I think, has highlighted perhaps a missed opportunity, which I'm sure colleagues will be remedying before the next time it comes to the Health and Wellbeing Board. So Dean has proposed the paper. I am happy to second it. Are there any other colleagues? Yes, so Ben, if you could introduce yourself, you'd like to speak?
Thank you, Chair. So it's Ben Hollands from Midlands Partnership Trust. I am the Health and Wellbeing Strategy Manager there, standing in for Zaffa today. One of the significant pieces of work going on at the moment is the community mental health framework, which is a big transformation of community mental health services. And as part of that, there's a big needs analysis which is done, which looks at health inequalities. And I just wonder whether we need to consider the kind of Armed Forces Covenant within that, and that population group particularly. Sean, you mentioned that you'd done some insight work. I just wonder whether that could be shared so that we could take a look at that and see how that could be factored into the community mental health framework.
Yeah, happy to share that report with you, Ben. It was an appendix within this report, but I'm happy to directly send that round to the board chair if that would be of use to Ben and the rest of the board members.
I'm sure it would, Sean. Thank you, and thanks, Ben, for that. I'm sure you're right. It feels to me like a mental health framework needs analysis across our communities should absolutely be factoring in the work around the Armed Forces Covenant, and that's precisely why the legislation's in place, so or is coming into place. And the benefit of board attendance, so that's brilliant. Thank you. Okay, so I haven't got anyone else indicating to speak. The report's been proposed by Councillor Dean Carroll. I've seconded it. I'm going to wait to hear whether anyone is going to object to us agreeing the report. The recommendations are that the Health and Wellbeing Board note and consider the impact of the proposed legislation, and that the Armed Forces Covenant lead will update the Health and Wellbeing Board and work with the partnerships manager Penny Basin when further information about the legislation is released. So that is approved by the board. Thank you very much. So the next item on the agenda item 8, is the warm homes, and I'm hoping that we have Simon Ross here from March's Energy Agency. Simon.
Yeah, Chair, good morning. Thank you very much for the opportunity. I am here. I had a few problems getting in, but with the help of your colleagues, I've managed to get myself here, so thank you. Shelley, is it possible to put the slides up on the screen? How does this work? I'm sorry, this is my first board meeting. Yeah, that's it. Great, thank you.
So, I'm going to ask everyone else to mute ourselves because there's a little bit of echo on the background, Simon. But if you could just introduce yourself and then talk us through the slides as you need them changing. If you just ask, then we'll go on to the next slide for you. Thank you.
Okay, thanks very much indeed. Hello, thank you for the opportunity to present to you for the next couple of minutes. My name is Simon Ross. I am the director of a charity based in Shrewsbury called March's Energy Agency, and our work really is around health and housing. And I was interested to note Nikki's earlier comments about climate change and economic regeneration as well. I won't dwell on those now, but they are of interest to us as well in passing. I want to just talk to you about a project that I'm calling Healthy Homes Shropshire, and it's really under the umbrella of some work that we're doing with Shropshire Council at the moment for a long-standing project called Keep Shropshire Warm. And if I could have the next slide, please, Shelley. So this is what we're going for, and so we've put a bid in with the help of Valcross, and Chair, thank you for your letter of support in relation to bringing this bid forward. We've asked for £210,000, ideally over 2 years, and I've got a question mark there because it's a competitive tendering process, so we might or might not secure it. The big red ring at the bottom left-hand corner is giving an indication of the size of the funding available. It's 50,000 up to a maximum of 2 million. So actually I could have gone quite a lot bigger, but I chose really to go with a project that felt like about sort of right in terms of the size and scale for where we are. The nature of this money really comes from the housing side, so it's energy companies, British Gas, E.ON, etc., making mistakes, being fined by Ofgem, and then that money being pooled centrally and made available to charities like us to bid in against to help people who are struggling in cold homes. So this is the 10th round, and we've had quite a lot of success with the programme in other ways, including setting up a new energy advice service in Telford and Wrekin, for example. But this time really I'm looking to focus the opportunities into Shropshire and supporting Shropshire residents. So if I could have the next slide, please. So I've just put this up just to give you a very brief range of the different bits that we try and align to bring Keep Shropshire Warm to a point where it can really try and support struggling householders in Shropshire who are struggling with cold homes. I won't go through all these in detail, but in essence, through these different partners, we have access to a variety of funding that we use to weave in and build upon the Shropshire Council funding to provide the core of Keep Shropshire Warm. That includes access to first-time central heating and both a rural solution and an urban solution, so mains gas and an off-gas solution. We're working with a number of providers to offer emergency heating repairs and new boiler replacements, to access cavity wall and loft insulation and internal wall insulation. We're working with other partners, Age UK, Citizens Advice, Western Power Distribution, to provide casework support, home visits around billing issues, debt issues, and a variety of sort of softer support mechanisms to support residents who are struggling with a cold home. So really, it's a combination of both the capital funding routes, which are available through 3 or 4 different funding streams, and the revenue funding streams for the softer measures in terms of helping the householders around energy debt issues. If I could have the next slide, please. So in putting this presentation together, I was struck by the JSNA. I know that was item 6 earlier on, but I found this on the papers from your last meeting. And in terms of the householders we are supporting now, not everybody, but we estimate somewhere in the order of 40% are reporting a health condition of some description. And I was interested just to do a very rough correlation with those that we're supporting with the JSNA. So I've highlighted the ones in purple here. So we are supporting householders now with cancer, with cardiovascular disease. I've actually missed educational outcomes off the top as well. So really young families in my language. Next slide, please. And also local residents with mental health issues, with dementia, with musculoskeletal conditions, who are carers. Those in food poverty, those with end-of-life issues, loneliness, isolation and frailty. And our support really is around, oh, your heating's broken. You've got no money to pay for a repair. Oh, you've got £800 worth of fuel debt. It's stressing you out of your head. It's that level of sort of support that we're providing. And we do what we can with that funding arrangement that I described to support people to be warmer and more comfortable at home as best we can. Next slide, please. So I've got a couple of very brief examples of some of that work, just to maybe sort of flesh that out a little bit very briefly. So the first is a single mother with health issues. Her child was sitting GCSEs at the time. It was January. I remember this very clearly because my own lad was doing the same at the same time. The boiler had been condemned. There was an open coal fire only. And this had probably been going on for years. I've put a question mark here because, to be honest, we don't actually know. It was the comment from the local contractor who did the work, and he said, look, this boiler has been leaking for so long that the floorboards on which this thing is suspended have rotted through. So it does raise a question in my mind about, you know, what has the impact been on this child's development? And the answer is, frankly, I don't know. Anyway, we were able to get a new boiler installed. We brought 2 sources of capital funding again for this particular one, and a lovely comment from the mother there. I'm so happy. The attitude of all people involved was great, really trying to help and do positive things. So that's one example. Next one, please. So this actually was a referral that came through from the ICS, and a gentleman, I'm going back about 18 months now, in Royal Shrewsbury Hospital, and we were able, within 48 hours, to get his broken boiler fixed. My colleagues were able to somehow work out that his neighbour had a key for the home. We were able to get one of our heating engineer partners out. He got the boiler fixed, and that was able to allow the gentleman to be discharged back to home again. So the cost to the NHS for this, looking after the patient, you know, I do have a question mark in mind, but I've no idea. For the heating repair, there was no cost. We brought the funding for that particular one. So I think, again, it's a question rather than a statement. It's how many other people like that would we be able to help in the system as well. Next slide, please. And then this is perhaps at the most complicated end of householders that we're looking to support. We ended up with a first-time central heating install worth of the order of £4,500. A lady in her 80s, bedridden, mental health issues, high blood pressure, carers coming in every day to support both her and her 2 adult sons who were living with her as well. They were nominally her carers, but were also struggling as well: Parkinson's, mental health issues, high blood pressure, and not working. My colleague found 1 storage heater in the home and electric room heaters upstairs, and his comment, I put it in speech marks there, the house was freezing, and it was April. So we had 2 phases of engagement here. The first was a referral through from Age UK, and we tried to support them with a gas connection at the time, and that failed. And again, his comments there was a sense of chaos and clutter in the home. So a year later, we had another referral through from the same household for occupational therapists. We were able to get the consent from the mother to sign for the work to go ahead. And then we were able to work with the contractors and family members to get first-time central heating installed in the home. So again, I think really these are questions rather than statements, and they're really relevant for this opportunity here. Is, you know, how best can we work with other agencies? And we do know from sort of public health work that low indoor temperatures do increase blood pressure. So what impact did this first-time central heating have on their blood pressure and their mental health? And I don't know, and I'm honest about that, because it's as much as we can do to get the first-time central heating in, and then those connections with health and that kind of wider health, just, you know, we can't make them at this stage. So next slide, please. So this is my final one. So really just summarising the opportunities as I see them around the Healthy Homes Shropshire project. If we're successful with this funding, and I should hear in the next 2 or 3 weeks, then we will be able to support an additional 1,500 struggling householders in Shropshire with energy advice and support, with home visits, with casework support. We're also working with Citizens Advice and Age UK, if we're successful in this, to be maximising the benefits and the income for the householders. And if we're successful, then delivery will be April 21 through till March 2023. So at the moment, we do have referral pathways through with social prescribing and community and care coordinators, but I think there's quite a lot more that we could do to be developing those. And I've tried to pitch this fund in such a way that actually we've got some additional revenue support from our side to be thinking about those with health implications, and then be feeding that back to the social prescribing, the community and care coordinators, maybe the integrated care services team as appropriate, and to say, look, here are some people that you've passed over to us. This is what we've been able to do for them, to support them to be warmer and more comfortable at home. Can we have a conversation about what that means to you from a health perspective? And I'm, you know, just from this morning's conversations, I'm hearing, my instinct is telling me that there are a lot of opportunities out there. So at this range, I hope that if we're successful, we can have 2 years worth of conversations just to start to open this space up a little bit, develop a sense of sort of shared understanding, and see where we can take it. So my final bullet point is we're a small charity. We're based in Shrewsbury, and we're also seeking we have a small board of trustees. It would be wonderful if we could find a trustee with a kind of health and social care background to help support our work and think about this more strategically over the next 3 or 4 years as well. So thank you, Chair. That's the end of my presentation, and I'm very happy to take any questions or comments. Thank you.
Thank you, Simon. Very valuable report. Thank you for bringing it to us, and colleagues certainly won't be surprised. I was very supportive of the bid that you were making. I have a few colleagues who've indicated they'd like to speak, so I'll take them in order. Karen, if you could introduce yourself, please.
Thank you, Chair. So I'm Karen Bradshaw. I'm the Director of Children's Services for Shropshire. Simon, really helpful and informative report there, actually, in presentation. And I suppose a sort of a question and a comment all sort of combined. So I have lots of social workers who go into lots of families' homes with obviously families with children. These are families who are often perhaps not engaged in with a social prescribing group, but are very vulnerable families. So our social workers see children's homes, and so I suppose my question is, there's a good connectivity there, and how can we make referrals in for those families?
I mean, the easiest is we've got there's a free phone number, 0800 112 3743, which is ringing around my colleagues who are all kind of virtually operating at the moment. But when we get through COVID, we'll be back in our office in Shrewsbury, and we can go from there. I mean, it's as simple as that. We've undoubtedly got a sort of, probably a Google Docs form if you wanted to look at some sort of encrypted sharing of data. But to be honest, if you've got a name and a phone number, we can go from there. That's at its crudest, and we can pick things up from that point, Karen. So it's pretty straightforward, really. I'm happy to take that offline and just provide some information for you subsequent to this meeting to help facilitate that process.
That would be really helpful.
Okay, I'll do that for you.
Thank you.
Thank you, Karen. So Laura, if you could introduce yourself, you'd like to come in?
Yeah, good morning. Laura Fisher, I'm Service Manager for Housing and Occupational Therapy, and I actually manage the Keep Shropshire Warm team within Shropshire Council. So morning, Simon. Just a comment really, just to back up and echo really what Simon was saying about the great partnership working that we've got across the council and with Simon and his colleagues. And just to sort of say that there are links within the team and the work that they're doing around climate change as well. So this may well be a piece of work that we could bring back at a later meeting to maybe expand on and talk about some of the other work that's going on around fuel poverty generally. And then also just to link in with Karen, I mean, I wonder whether or not internally, Karen, it'd be useful if I asked the team to actually come to DMTs or team meetings and actually had a conversation with your social workers to be able to link in with the guys within the council, but also with Simon and his colleagues going forward. That might be quite a good link to make.
Yeah, we can take that up offline.
Brilliant. Thank you.
Thank you.
Great.
Thank you,
Thank you,
Laura. Rachel, you'd like to come in if you could introduce yourself, please.
Thank you. Rachel Robinson, Director of Public Health. I think it was just really a comment, Simon, a really helpful paper, and I think it really powerfully you demonstrated those links between health and housing, and the case studies particularly I thought were really powerful. I think just to link it up with the work we want to do with the JSNA to make sure we really need to bring some of this to life and I think it demonstrates really strongly those wider determinants of health, how important they are to keeping people healthy, and just really I think as you've demonstrated in the individual priorities we've got, but with this place-based JSNA, I think we've got a real good opportunity to bring yourselves and others in to really bring that together. And so it was really more of a comment, but thank you.
Great, thank you.
Thank you, Rachel, and thank you to colleagues. We are, I think, noting the report, and obviously we are quietly optimistic, although as you say it's a competitive process, that we'll be fortunate enough to be successful in the bid. But I think the suggestion from Laura that we bring a further update back, particularly in relation to fuel poverty updates, which we have had here, the Health and Wellbeing Board before, but I think to certainly if the bid's successful in a couple of months' time, once things have settled down and we've got more of a plan, I think it'll be very helpful to bring an update back to the board. So thank you very much, colleagues, and we're happy as a board to accept the bid and wish you all the best with that going forward. And thank you for bringing the report to us, Simon.
Great. Well, thank you for the opportunity, Chair. I very much appreciate it. Thank you.
Okay, so item 9 on the agenda is the COVID-19 update and flu vaccinations, and I think the anticipation is, Rachel, that you and David Evans are going to jointly take us through this part of the meeting. So if you start off, Rachel, we'll see where we go. Thank you.
Okay, thank you, Chair. So Rachel Robinson, Director of Public Health. And absolutely, I'm going to start off and just give a kind of an overview, just briefly touch on the flu vaccinations, and then hand over to David to do the broader piece and the good news around COVID vaccinations. So just in terms of flu vaccinations, I know it says verbal update, but I have just put a small paper together just so that it's there for the records. But in flu vaccinations, you'll see that the uptake we've had across the flu season has been one of our best uptakes, and we've seen over 83% uptake in our over 65s, and also in our at-risk groups almost 62% uptake, which is fantastic. That, coupled with, I think, some of the measures that we've seen in place because of COVID, has meant we have actually seen a reduction in flu, but it's still really, really important, and it's really good news that we have managed to get the uptake across all of our at-risk groups. So moving on to COVID, there's some information in the paper, but I'll bring you the board right up to date where we are currently around COVID. So in terms of just an overview of the situation, our rates are, I'm glad to say, since when we met in January, are now falling. You'll see that from the paper. Our current rate is actually 93.5 in all ages, which is a 30% reduction on the previous week, and we're down to a rate of 61 per 100,000 in our over 60s. Both of those are good news. Actually, in our latest data, it suggests the rate has fallen even further, and our daily line listing to around 81 per 100,000. That is good news. That brings us back to the level we were at in October, which, if colleagues remember, that is before we went into that second wave. So whilst it is good news and we are certainly going in the right direction in terms of our overall rates, just to remind colleagues, we still are in Shropshire, as in lots of areas of the West Midlands, above the England rate at the moment. Our rates are higher, and compared to where we were in the summer last year, our rates were around 7 per 100,000. So we are definitely going in the right direction. It's really good news, and we're starting to see that reduction, and that significant reduction in our over 60s, but we still have a way to go. So I think I just wanted to flag that we are seeing an impact on our deaths as well, which is positive. Our deaths are falling. When we met earlier in January, our death rates were increasing, and we peaked at around 35 deaths in 7 days, which is a significant number. We're now falling, and our deaths are around 16 in the last 7 days. And hospital, the situation hospital is improving as well. But again, so whilst it's really good news, and to bring to the board that we have got an improving picture, we still have work to do, and that is something that I really want to press. So there's a few things I just wanted to particularly draw out in terms of COVID. Firstly, is our vaccination rate, which is rising significantly. I'm going to leave that to Dave to talk about. The second important part of what we're doing is testing. So our strategy to take us forward over into the next year is vaccinations. The other important bit is testing, and I've included that within the paper because I wanted to make colleagues aware of the testing offer across Shropshire, and we are increasing this. So we do have one of the highest testing rates within the West Midlands, which is exactly what we want. We want to be testing, but we want low positivity. So we want good testing, but actually finding very few positives, and that's where we're getting to now. So the more we test, the more assured we can be that we've got lower rates in our population. We have a really good offer across Shropshire for both symptomatic testing and asymptomatic testing, and that we have been increasing that over the past few months to get us ready as we start to go into that roadmap out of lockdown. So our testing capacity, we have symptomatic sites that people can visit, both in static sites. We've got 3 static sites across the county, and actually 2 mobile sites at the moment that we're bouncing around the county, so that people can get really good access to testing when they have any symptom, no matter how mild, not just the 3 symptoms, but also other symptoms such as sore throats and headaches and runny noses. So we have that offer, and a really good postal offer that I'm glad to see people across Shropshire are taking up. The other big important part of our strategy at the moment is around asymptomatic testing. So those people who don't have symptoms but get regularly tested, and you'll see that that's part of the government's roadmap. So we have been opening up that offer to key workers, people who can't work from home in lockdown. We now have across the county, we have 3 sites that we support as a council with our volunteers that we run. One at Craven Arms, one at the Lantern in Shrewsbury, and another one in Wem. But we've also added to that last week a suite of pharmacies who are offering asymptomatic testing that can be booked, and some pop-up sites that are currently, we have one in Shifnal, one in Bridgnorth, and one in Oswestry. As of next week, the Oswestry site is moving to Market Drayton, so people can just walk in without appointments and get asymptomatic testing. We're encouraging people to do that twice a week where you can't work from home. And as we go through the roadmap, you can see that would become increasingly important. We're also supporting businesses who need to train and can then run that through their own workplaces. And we've got a really good offer in Shropshire that's going really well, and we've trained over 100 people in that model, and businesses are coming to us for that support, and our public sector colleagues, including, for example, the fire service. So we've got a really good comprehensive offer. Just a final point to add to that is now that you'll have seen that's been extended to parents. So as we've got a big important date on Monday as our schools start to go back, which we'll be watching very closely. And part of the government announcement was that parents can get tested twice a week. They can have tests. They can go to one of our sites, and we're encouraging people to go to one of our asymptomatic testing sites. But also we can also go and collect some of tests from some of our 3 local testing sites at Ludlow, at London Road in Shrewsbury, or Oswestry. So there is an offer there. You can see that. So vaccinations, testing are 2 really, really important parts of our offer as we go into the roadmap. The final point to make is that we do, as you would expect, and the board would be particularly interested in, we have a big focus on inequalities. I think COVID has certainly highlighted the impacts of COVID have been felt across our whole population. Everybody has been impacted by this, but some groups have been disproportionately affected. And we're seeing that playing out in terms of our vaccination programme, but we're also just generally seeing that playing out. And as a health and wellbeing board, we have obviously a significant role to play in helping to tackle those inequalities. So there's a huge amount of work that is going on around that now, in terms of making sure that people have access to the things that they need and the support that they need. So I guess that's that was the overview I just wanted to bring on COVID. I think we are going into the roadmap. As being laid out by government, that is all dependent on our data. So, and I'm pleased to see that we are taking a cautious approach. We want to get this right. I guess my big, a huge thank you to everybody for all the work that they're doing across Shropshire, both our partners, our voluntary sector, but obviously a huge thank you to our population of Shropshire. I guess my key messages are, keep taking your vaccination. Please take up the testing offer that's there. We'll work together to tackle inequalities. We'll keep being cautious, but please keep going. We're on, we're on the way on that roadmap. Thank you. Oh, sorry, I'll hand over to Dave now.
Okay, Rachel, just before you hand over to Dave, there was just a couple of things. This asymptomatic testing, and I've talked before about asymptomatic testing at the board. What I think I'm clearer about now, which I wasn't before, is the purpose of asymptomatic testing. And you talk about it being part of the roadmap. I'm aware that my wife, who works in healthcare, tests herself twice a week. She's got lateral flow tests at home, and she does them and sends them off to an NHS website. But what we're saying here is quite clearly that people who are essential workers or people who are unable to work from home should be having themselves tested twice a week at all of those opportunities that we've now got available for asymptomatic testing. So if they've got no symptoms and they're out working in the communities, either as an essential worker or any other type of worker, but someone who can't work from home, the expectation now is that they should be rocking up and getting themselves tested, either booked in advance or at a drop-in twice a week. And I don't think that, and I might have missed it, but is that now starting to come through as a clear message to everyone as we emerge out of lockdown, or is that something that we're just doing in Shropshire?
I think that is the direction we're going in. So to get us to move forward through this roadmap, what we need to do is use as many tools as we've got, and vaccination is clearly one really important tool. But the biggest thing we can do is keep the infection rates as low as possible. It doesn't matter how good our vaccination programme is. If our rates are still high, we're more prone to get mutations of viruses, we're more prone to get outbreaks and spread. So actually the biggest thing we can do is to get those rates down. And what testing allows us to do, and particularly asymptomatic testing, is it's another tool to try and identify people who are infectious but may not know. Particularly, we know up to a third of people that don't have symptoms. So it's a tool that to help us to pick up positives we wouldn't otherwise have picked up. It is not to be we still need to continue, and I can't stress this enough, doing the things that we're doing around social distancing, mask wearing, all those other interventions. It's just an extra defence that we've got to protect us and to identify, and all the time we're trying to identify people who are in our community who may not know they've got symptoms, and that is why it's such an important tool. And we're really lucky, if you think about where we were last year to compare to this year, that we have that opportunity. And as you track through the roadmap, you see more and more businesses starting to return, more and more people will be out and about in our community. So from the 29th, the stay-at-home mandate will come off if we continue and we don't see any surges in population, and therefore more people will be, although people are asked to still work from home where they can, people will be businesses will start to return. We'll start to see that gradual opening up, and this is as much for us ourselves as employers. As you said, it's been offered to healthcare, but now we're broadening that out, and particularly as schools start to go about that offer to parents. It's just about gradually open that up and taking every opportunity we can to identify people who may have COVID and then ask those people to isolate. These are all really, really important tools that we need to use to continue, because the ultimate aim is to get those rates down as low as possible, and particularly in some of our vulnerable populations as well, because otherwise we'll just see outbreaks emerging. And it's a bit like the vaccination scenario. We can vaccinate ourselves, but if you haven't vaccinated the rest of the world, we still have to bear that in mind. It's not, so that is what we're trying to do all the time, just as many layers of that cheese or that pie or whatever as possible, and testing is a really important part of that.
So could I ask then, are we as a system going to be advising, or are we already advising businesses and organisations that have workforces out there for all of their workforce to be tested twice a week, asymptomatic testing? Because I'm not aware that messaging is out there.
That messaging is starting to come through. Obviously, some of it's been rolled out gradually, I think, is what I would say. So that is the point that we are in the horizon that we're getting to, that everybody will be doing that. At the moment, it's some businesses over 50 are being asked to access if they want to access testing, and that's being made available. We're supporting businesses, but I think you're right. We need a very strong message that this is the way that we're going, and certainly we've been pushing out key workers to come and get tested routinely. So we are pushing that out, and I'd welcome the board's support in making that more widely known.
Okay, well, it starts here. Thank you, Rachel. I've got one colleague who wanted to ask a question, and then we'll go to David Evans. So, Jackie, you wanted to come in. If you could just introduce yourself.
Yeah, I am Jackie Jeffrey, and I'm the Voluntary Community Sector Assembly Rep on the Health and Wellbeing Board. I just wanted, I don't know if this is the right place to do it, and apologies if not, but the impact of COVID, and my wider question is, what are we doing as a Health and Wellbeing Board to understand the wider impact that COVID is having? I mean, and these are all things we've talked about, but I'm starting to get anecdotal evidence coming and comments coming from the voluntary sector about the impact of COVID, and especially where there's a loss of preventative and rehabilitation services that have obviously had to stop over such a long period of time. So Age UK particularly are talking about how their clients are having difficulty in accessing NHS services, whether that's seeing their GP, access to memory service, or have x-rays or surgeries. The impact they're having now is that they're seeing a cohort of clients coming to them for help, which are in a far worse condition than they were before COVID, so we're seeing physical conditions deteriorating, certainly over 55s, especially people looking after people with dementia who are waiting a long time to speak to memory service. So it's a wider comment. I mean, I think Rachel and the public health and your response has been marvellous, and absolutely support that wider communication. At this point, what are we doing as a Health and Wellbeing Board to start collecting and understanding the impact, because it impacts on the systems, it impacts on the JSNA, and it impacts on inequalities as well?
Okay, thank you, Jackie. The line was terrible, so I'm sorry about that, but I will, just for the benefit of the board and any public listening, just summarise what your challenge to the Health and Wellbeing Board is. and it's to what extent is the Health and Wellbeing Board working to gather impact of some of the longer term effects of COVID, particularly around delayed access to rehabilitation services and other physical therapy services that have been delayed due to the pandemic, and how are we going to seek to work with the system to make sure that those inequalities are minimised. So if you could mute yourself, Jackie, I'll let Rachel come back, and then we'll bring David Evans in, if that's okay. And I think then Lynn and Julian wanted to ask questions. So do you want to respond to that, Rachel?
Yeah, I mean, I think it's a really, really good point and really good challenge. We are starting to look at that. So we have working with some colleagues, we've been working in the background around this, looking at living with COVID, if you like, and part of that is understanding the impacts. And we have recognised that this is a long-term plan, that this is not going to be over on the 21st of June at all. And that's the best case scenario in the roadmap. There's a huge amount of work that is going on now, and then over the next 2 or 3 years, this is going to become part of what we need to address going forward. So there's a piece of work that's already been started to collate some of those impacts of COVID. It's a starting point that some colleagues have started to collate it within the council, and we are just at the point of sending that out. So I suggest, actually, Jackie, I think you're right, if we could send that round to partners, because it is so wide ranging, the impacts from the health response to housing to employment and education, and it's all interlinked as we've described. So I think what we would want to do is have that comprehensive understanding at a system level, at a sort of Shropshire level, if you like. And I would love to have colleagues' input, and I think the Health and Wellbeing Board should be input into that. We've started to collect some of the evidence from national and local, through as well the social and economic task forces that have been set up. So bringing all of that together, and through the work we've been doing around inequalities and throughout this, and our engagement teams. So I think that's the first piece. We are at that point of starting to collate that. I think you're right in terms of the JSNA. That will help us get more information as we go out and start to do this process. We'll really understand more of those impacts. So that's a longer term assessment, and also understanding of how we can respond. But I think the immediate bit we're doing at the moment, and it would be great, and I think we should bring that back through the board. And we do need to look at our health and wellbeing strategy, because we're coming to the point of refreshing that now as well, and it absolutely needs to be grounded in the impacts of COVID. So I think it's a really good challenge. I think we've started it, and it would be great to get the Health and Wellbeing Board partners' input into that. It will start to form the planning as we are going on through the next coming year. We're talking 2 or 3 years. This is not an immediate, as I said, response, but also how we also assess the impact COVID's had in terms of the way that we've worked and the way that we want to capture some of those opportunities moving forward. So hopefully that gives you some reassurance with considering, but I think we need to involve other partners as well. And I've noticed comments around kind of mental health issues. We're trying to pick all, because it's so wide range in the impacts of COVID. We do need to put all of that together, and it needs to inform all of our plans how we work going forward.
Thank you, Rachel.
Yeah,
thank you, Rachel. Julian, if you could introduce yourself, you'd like to ask a question.
Yeah, thank you. Julian Povey, Chair of the Shropshire CCG. I suppose my question is about the venues and the timings and the method of access for the asymptomatic lateral flow testing. Because I'm a health worker, I do my lateral flow testing twice a week at home, and it's very, very easy to do and then easy to report online. I'm just wondering, if we're trying to target people and get people, surely the site in Shrewsbury should be more accessible and should be walk-in rather than being booked in advance. I've got a friend who works in Liverpool, and he said basically he does his because the walk-in site is within the city centre. It's where he walks past at lunchtime every day, so he goes in twice a week. Whereas ours is a book your appointment in the Lantern in Halscott, which obviously reduces the ability for people to do that. Surely a centre, walk-in centre with no appointments in the centre of town or near the bus station, would be a better place to have a site.
Yeah, thanks, Julian. I mean, at the moment we're trying a mixed model. So we've got several well, we're trying to do several things. One is just increase coverage, because obviously Shropshire being such a rural county, it's not been as straightforward as it has been some of the kind of urban areas. So we are trying to come up with a model that works both in terms of delivery but also in accessibility. So we have got pop-up sites, so we are working out how well the uptake is going in those sites, and we can move those around. They're called pop-up because we can put them in other areas where we've got greater demand. One of the reasons we went for the pharmacy model is to make sure we've got really good rural access as well, so that yes, you do have to book it just obviously for the pharmacies time, but again, that's more for their so the pharmacies can manage that. But again, it's to get really good access, and we have quite a lot of pharmacies within Shrewsbury that are accessible. And then obviously the Lantern, we've used a booking system. We have been flexible, and I'll let Penny come in a moment on that as well. So we have the flexibility, but it's trying to work through what works best. As I said, we want a mixed model. There is also postal testing available for parents, and there is a collection testing so that people can do it at home. But what we're trying to encourage in Shropshire is, particularly for your first test, that you come and get them done at a site, because there is a technique to doing this. And the main thing with the lateral flow testing is that you do the test well and it's accurate, because it picks up that whether you're infectious or not. It's different to the PCR test, which when you've got symptoms. So we're trying to encourage people to come and get tested first, to be involved in one of our sites and have it done a couple of times, and then after that we can look at some of the other models that are available, which will give that greater coverage. But take on board your point, and perhaps Penny might want to come in on that.
Penny might want to come in on that, but I'd just like to bring Lynn in first. Lynn, I think you wanted to contribute to this, didn't you? If you just introduce yourself, please.
Thank you. So Lynn Corley, Chief Officer for Healthwatch Shropshire. I just wanted to raise two things really. I just wondered, as we come out of lockdown and there's that increased need for people to get lateral flow testing, is there any chance that we might run out of tests? Or be challenged in terms of the numbers who are, especially if they're going twice a week, every week?
Yeah, so I think that's why the policy, we're trying to align it to the roadmap. So we're focusing on people who can't work from home at the moment and who are more mobile. So that's one of the reasons that we're making that clear, that we want people to be able to test where they come out. I think it comes back to Lee's earlier point around the publicity around this. So we've focused on people who have to be at home. We are now, obviously we expect more people to be coming out, so parents, so we've got an option there for parents, and then obviously some businesses will be starting to reopen, and that's why we're rolling this out. The government has an ambition to get to the wide population being tested, and we're working to kind of June, if you think about the roadmap. So I think that's a really good point, Lynn. That's why we're rolling this out, but we have certainly increased capacity across Shropshire to be ready for this. I think that's, and that capacity is there at the moment. There is capacity there at the moment.
The other thing I wanted to just pick up on was leading on from the comment that Jackie had made about the long-term impact potentially on people's health of lockdown and the pandemic. And I would expect that the third sector will be some of the first people to see that impact on the people that they're working with. We've already heard about Age UK and that older age group. I just wonder how health and social care are working with the third sector to get that early information in order to be able to respond as quickly as possible when things start coming out of lockdown to address those needs.
Thanks, Lynn. Yeah, I mean, a really good point. Some of that work's been done through the various task forces that have been set up and through our community reassurance teams having those links in. But I would, and through our links to obviously the assembly, and I think we need to strengthen that absolutely. What we need to, so much of this is anecdotal at the moment, but we need to collect all that anecdotal information. We all know things like mental health. We're not going to see the biggest impact for certainly a few years down the line. A lot of this is hidden at the moment, and we know that it was only when the measures were released, when lockdown was released last time, that we saw some of and children went back to school and we start to see some of that impact. That's when you really feel it. So we absolutely need to be working with partners for them to feed that into us. So some of the mechanisms are in place, and I guess you're absolutely right. We need to make sure we strengthen those and get that intelligence and information through, so that we can respond as quickly as possible. We have got plans in place, and a huge part of that, just to reassure you, is working with the voluntary and community sector. So we've put some of our funding aside that we've received from government to make sure that we can respond in the way that we need to. But I think we need to work together.
I was just going to say, because some of those third sector organisations have continued to work with people during the lockdown, albeit over the phone and remotely, but they have got that live experience of hearing about what has changed for people. So yeah, I just encourage those conversations.
Thanks, Lynn. So Chris Preston, you wanted to come in, I think.
I think that's been picked up, Chair. Thank you, by Rachel. It was about the mental health. It's just making sure. So we tend to focus a lot on some of the physical issues and the short-term issues, but the mental health implications, particularly when we're looking forward, it's really important we pick those up as well and put in the prevention activities required to avoid those issues escalating. So thank you. I think that's been picked up.
Okay, thank you, Chris. So Penny, if you could introduce yourself, you'd like to come in.
Thanks, Chair. Penny Basin, Head of Joint Partnerships. Just wanted to update that, I think you're right, Julian, around having walk-in access in the town centre, and we are working with the university at the moment to see how we can do that collaboratively with the university. So that is in train. I suppose some of the thinking about that was doing it in line with the kind of opening up of the town centre as we come out of lockdown. So that was kind of our timing. But also, as Rachel said, there are pharmacies available in the town centre to go and have the lateral flow now. So if people want to use the town centre, unfortunately, it is bookable. But I think there's the issue there is around space and management, the infection control management. So it's important for pharmacies to be able to have that bookable situation. And then also, if I can just say, Chair, that with regard to Lynn's comment about working with the voluntary sector, just building on what Rachel said, we can also, I think, link to, as Tanya asked for, a evaluation of the winter support service that went in this winter, in particular working with referrals from social care and from PCNs, and I think there'll be links across to that evaluation and understanding people's experience. So there's a range of ways in which we'll be gathering people's experiences and, as Rachel said, investing in understanding experience, and then also investing in the voluntary sector going forward.
Thanks, Penny. So David Evans is now going to come in and talk to us about the wider vaccination programme and his take on COVID. So David, over to you.
Thank you, Chair. David Evans, Accountable Officer for the 2 Shropshire CCGs. And before I talk about the vaccination programme, Lee, if I talk or make some comments around some of what's been said by Jackie and others.
That would be helpful. Thank you.
Because clearly, as Rachel said, 21st of June or whenever full lockdown finishes, and assuming we don't go back into a new lockdown at some point in the future, is not the end of where we are with COVID moving forward. If I just put some context around this, we've been in a difficult position for almost a year now in terms of things like elective surgery, outpatients, and a range of other services, including mental health services, not being delivered either at all or at full capacity. Now, in some cases, of course, we've continued to deliver very urgent cases when that's been appropriate and necessary for those individuals. But nonetheless, a lot of routine work across healthcare has been put on hold to one degree or another for close on a year now. And the recovery of those is going to take some considerable time. Now, we're really clear around, and we've issued statements again this week, that where people feel their condition has deteriorated and they've been referred into a secondary care service, be that physical or mental health, they need to go back into that service for a review and ask for a review to see if their prioritisation has changed. Where they've not yet received an outpatient appointment, we have asked them to contact primary care. But I have to say, if I was looking at elective surgery as an example, bearing in mind that the capacity constraints aren't just physical around buildings, they are particularly around staffing. I think we're looking at probably 2, 3, possibly even longer number of years before we get waiting lists back down to the position they were in before the pandemic started. Now, we do need to do everything we can to bring those down as quickly as possible, but it will be the same staff. We have got a tired workforce at the moment anyway, because of the constraints they've been under. We're not going to be able to get a significant number of staff coming on quickly to enable that to move at a much quicker rate than that. Of course, we will do everything we can, and I know colleagues in the acute sector will play their part in that, and we will use the private sector, as we have been doing over the past year, to enhance our ability to continue to deliver elective services. But this is going to be a long process. I wouldn't want anyone to think we can get back to pre-COVID type waiting list lengths within the next 6 months post lockdowns being over. That is not going to be the case. We will do everything we can. We need to make sure that we continue to review patients so they do get treated at the appropriate time. But I do want to give that message. And of course, for those patients with long COVID, there are long COVID clinics now in place who will continue to make sure that those patients in particular get the right therapy and treatment moving forward. So I hate to be the merchant of doom and give a very what sounds like quite a negative message, but I'm trying to be realistic about that as we move forward.
David, I think, and sorry to interrupt, but I do think that we should just pause for a moment and just think about some of the comments that Rachel was saying about the implications for our planning as a health and wellbeing board, and particularly about the type of information and the type of system updates that we need to bring back to the health and wellbeing board, because historically our planning for the the health and wellbeing board action plan would typically be sort of a couple to 3 years. So what we're actually saying, and I have to say I'm not surprised, but what I'm saying is that COVID recovery from a clinical perspective, from a system perspective, is going to be a number of years, and therefore we need to mainstream our approach in the health and wellbeing board to be sitting alongside that recovery from those impacts of COVID over that term. And so I think it's worthwhile just pausing and saying that is going to be the landscape, and we need to make sure that we facilitate those discussions here in the Health and Wellbeing Board, but also that we take the opportunity to update on progress of that longer ambition of clinical recovery. So yeah, just to emphasize that, following what you'd said.
And I would fully support and agree with that, Lee, moving forward. I do think that the restoration of services and the recovery from COVID, and that's across all services in terms of mental and physical health, will need to be monitored. And of course, the Health and Wellbeing Board will want assurance around how local services are responding to that.
Okay, thanks, David. You were going to go on to vaccination, weren't you?
So if I just go on to vaccination, which I think is probably a more positive message than the one I've just given, actually. So as of yesterday, we had given 187,866 vaccines across Shropshire, Telford and Wrekin. That does include a very small number within the overall number of second doses of, last time I looked at it, I think it was about 27,000 of those are second doses. Just to put that into context, because I just checked the figures actually while we've been talking, on the 9th of January, we'd vaccinated 11,440 people. So in less than 2 months, we've vaccinated over 175,000 people or given 175,000 doses of COVID vaccine, either Pfizer or AstraZeneca, in what, under 8 weeks. I think that in itself is a huge achievement for our system, and that's not down to health. I'll be quite honest, that is down to all partners. It's down to partners in health, including primary care, all of our acute partners, including Robert Jones and Agnes Hunt. It's down to the voluntary sector. It's down to other services like the fire service, who've been working at some of the vaccination sites, and it's down to colleagues in local authorities as well. But this has been a really significant achievement. And the first thing actually I'd like to say is thank you on behalf of the population, because clearly, of course, there's a lot more to do, and clearly everyone wants to get the vaccine as quickly as possible, and we are committed to doing that. But nonetheless, that is a significant achievement. And again, just to put it into context, if I looked at the two systems locally at the moment in terms of place, if I looked at the National League tables, because I will call them a league table, I know they're not meant to be described as that, but I will call them that. Shropshire was 8th in the rankings at the weekend for vaccination across over 65s. Nationally, and that's all of those cohorts in over 65s nationally. Telford was number 1, I have to say, across them. So if you looked at us across all of the other areas around the country, we have done incredibly well. I know there was concern that we had a slow start, and we did have a slow start, but we were always confident that we would catch up, and clearly have demonstrated that. There is still an issue around vaccine supply. So I do hear comments around we've got vaccination centres not operating at full capacity, and I have to say that is true. And we would like to operate at full capacity if we possibly could, but unfortunately there are still, as I'm sure everyone is aware, some constraints around vaccine supply. We have started over the past week or so beginning to push through second doses for those people who had their vaccinations in December and the beginning of January. We are sticking to the 11 and 12 weeks in terms of people who get second doses, unless of course we're trying to make sure that we minimise wastage, and we've got a couple of doses left over on a site at the end of the day. It's possible then someone may get a second dose. I know there's still concern around other frontline occupations like police, fire service, teachers, etc., but the evidence is quite clear, and it was reinforced nationally again last week. To get the biggest public health impact, we need to make sure we go through the age cohorts, because the older you are, the more vulnerable you are in terms of both the potential to catch COVID, but more importantly, the severity of it if you do catch it. So that's probably all I was going to say, Lee, at this stage, other than to just reinforce a huge thank you to all partners for the efforts they've played in what I think at this moment in time is a strong performance locally. We will be making sure that we do everything we can to vaccinate the population, and our modelling locally suggests that we can complete first and second doses by the end of July.
Excellent. Yes, thank you, David. Well, I'd like to add to that and congratulate everyone involved in the programme, because, as you say, superb achievement by all involved in what was, as you say, a little bit of a slow start, but nevertheless, all of the targets and ambitions were comfortably met, and so in that respect, very much to be celebrated. It doesn't, of course, and this is a public meeting, it doesn't, of course, negate the need to take the basic precautions around social distancing and face coverings that will continue, I imagine, for the foreseeable future. I remember thinking that seeing pollution masks in Japan a couple of years ago looked very strange. I've completely changed my view of people walking around in masks in the current circumstance. So yeah, absolutely. So comments, questions by members of the board. I've not got any indications other than some quite right congratulations from colleagues in the notes. So the two reports, both your vaccination report and the COVID update from Rachel, are to be noted by the board. So I will certainly do that. I'm sure that colleagues will be happy that the board notes those appropriately. And that neatly brings us on to the last item on the agenda, which is Chairman's updates. I don't have any official Chairman's updates. I've only got one brief update to thank my colleague co-chair, Julian Povey, Dr. Julian Povey, who it is his last meeting as co-chair of this board. So he will no doubt be not getting quite the same opportunity to look forward to the huge amounts of work that I think we've volunteered ourselves for in the coming weeks and months. Two items to note, which we will put down in the minutes. The for future board items, the to review the evaluation of the WIPS contract, which was agreed, and also to review the evaluation of the Shrewsbury Rapid Service contract. Both of those, along with reviewing our joint work on the Joint Strategic Needs Assessment. Julian, did you want to comment? I don't think you'd want colleagues or your patients thinking that you're completely retiring. So did you want to just speak, Julian?
I did. Thank you very much, Chair. Thank you. Just a couple of things really. One is to say, yes, this is my last meeting and I've enjoyed being the co-chair of the Health and Wellbeing Board and enjoyed being the chair of Shropshire CCG. No, I'm not retiring from work. I'm just leaving the CCG. I'm returning to full-time practice. Some other news really about post-April the 1st is that obviously Shropshire CCG in its current form is ending on the 31st of March, and it's as is Telford and Wrekin CCG, and we are forming a new CCG called NHS Shropshire Telford and Wrekin CCG. Which will probably be in place just for a year because of the white paper changes. Dr. John Pepper, a GP in Shrewsbury, at Belvedere Practice, is going to be the chair of the CCG. It's also, I do need to announce that, and Dave may want to comment, that Dave Evans, I would like to thank him for his time in charge of the CCG. He's moving on to a role as a director in the CSU for projects. Dave's been at Telford and Wrekin for over 8 years and has had the last year or so running both CCGs, and has been has contributed hugely across both systems, both Telford and Wrekin and Shropshire for the last for virtually the last decade. And I'd like to thank him, but also Dave is moving on, so there will be a new AO as well for the next meeting, and further information about that will come out in due course. So thank you, Chair. Thank you, everyone else.
Okay, Julian. And Dean Carroll wanted to speak.
Thank you, Chair. Yes, I just wanted to add that Julian's not the only co-chair who this is the last board meeting for. As I'm aware that you two are stepping down, Chairman, from this role, and I'd like to pay tribute to you. You've been co-chair of the Health and Wellbeing Board for as long as I can remember, and for the two, and of course my predecessor as the portfolio holder. And I found your support as the ongoing chairman of the Health and Wellbeing Board to have been absolutely invaluable over the past 2 years as portfolio holder. And I'd just like to thank you, and that it should be recognised the amount of work that you've put in over and above all of the other day-to-day work of a councillor. So I'd like to thank you as well, Chairman, and pay tribute to Julian as well. I found him to be an excellent chair of Shropshire CCG and of the two together, and I wish him the very best for the future. It's been a pleasure to work with him as well.
Thank you, Dean, for that. And I think Jackie Jeffrey wanted to come in. Jackie.
Yes, is that better? I've changed my microphone.
It is. You're crystal clear there, Jackie, just towards the end of the meeting.
Well, you know me, timing's a wonderful thing. And my timing is, I came in on a conversation at the beginning of the board. So do I understand you're standing away from the council completely, Lee?
I am, yes. I'm retiring from the council. Yes.
Okay. Well, can I then just say from a voluntary sector and the Assembly, a big thank you for all that you've done. You've been a marvellous supporter of the voluntary sector, and it's been great to work with you, and you get it, and I think you will be sadly missed, and I would just like to formally say thank you.
Thank you, Jackie. That's very sweet of you. That's appreciated. Thank you. Right. Excellent. Okay, well, with no further business, I wish everyone a healthy and happy rest of the week and weekend. And the next meeting of the Health and Wellbeing Board will be the 27th of May. Thank you all to colleagues for your support. It's been much appreciated. Thank you. Bye-bye now.
Thanks. Bye.
Thank you, Chair. Thanks.
Thanks, Chair.
Thanks.
Thank you.